Thank you very much indeed for inviting me to speak at this conference. We've heard a very important talk just now about the introduction of replacement or substitution treatments with methadone or buprenorphine. And for my talk, I'm also concentrating on that group of patients or the population who have problems with heroin addiction. In the UK, we have been very concerned with looking at whether we can make sure that the treatment is more than just the medication itself, and to make sure that it enables people to make fuller recovery. And there are some good lessons to be learnt, and there are also some warnings or cautions about how it's important to be very careful how this is done. So first of all, these slides will be with you. There's a list of my different involvements with government agencies, working with treatment services. So I'm a clinical doctor working in the addiction field and also working with third sector NGO agencies in the UK. I've also worked with the pharmaceutical industry and with drug policy review groups and charities. I wanted to remind ourselves, those of us who are doctors will have to declare the Hippocratic Oath, and essentially this has two important components to it. We need to work for the benefit of our patients who are ill and to avoid the two traps. On the one side, the trap of over-treating our patients, but on the other side, the trap of therapeutic nihilism, or a sense of failure about even trying to treat the patient. And it's between these two extremes that we need to be working. This leads us to conclude that whether we come from medical or other backgrounds, we need to be able to personalize treatment so that it fits the individual. Not all people are the same shape or size, and even if I fit one size today, I will be a different person tomorrow, and I was a different person yesterday. And so we need to make treatment in such a way that we can make it fit the individual and their circumstances. And this is frequently missing from treatments in the addictions field, which far too often insist on the patient fitting the shape of the treatment service, and it should be the other way around. There's a danger in the treatment, particularly in the public and political debate, that there is an insistence in the UK discussions at the moment on full recovery. And this is a very difficult and dangerous discussion. Of course, it is a good thing to be looking for full recovery for all people with problems, but we need to be clear, what does full recovery mean? Full recovery will depend on where I am in life and what circumstances are also difficult for me in other areas of my life. So full recovery needs to be understood as the fullest recovery that I myself can achieve in my circumstances. And it is not acceptable, and it is not proper medical practice to insist on some external definition of what full recovery means. And in almost all areas of medicine, we work with patients who achieve partial gains. They achieve partial recovery. So whether they are recovering from their heart disease or from their diabetes or from their depression, we will understand that there are stages in that recovery that are important, that there may always be some residual degree of vulnerability, but it's the individual and the personalized understanding of recovery that's important. This is very important in the addictions field because there is a danger that society or politicians or people organizing services will want to push patients to make recovery, to make the next step in recovery at too early a stage. And there is a danger then that you lose the gains you have recently achieved. And that is part of what good clinical care of each patient involves, is an assessment of whether they are yet ready for a change in the way in which they're managing their addiction problems. I was involved with an exercise in the UK looking at trying to have some terminology for understanding recovery in the addictions field. And we were aware it was a process. So it is not something that you either have or don't have, but as you make gains, you gain more of the positives of your recovery. So it's a process of recovery, and it's characterized by the voluntary achievement of control over your drug use, and that as a result of that, you're able to maximize your health and well-being, and that from that position, you then contribute in the rights, roles, and responsibilities of society. So where does this personalized perspective take us? It makes us realize that just being in treatment is not recovery. It's the gains you make as a result of being in treatment that are important. It makes us realize that abstinence itself is not recovery. There again, it's the changes that you manage to achieve. And so we then come to understand that medications can help somebody in their achievement of degrees of recovery, and that what we need to look to do is to how best to use medications to help people to achieve recovery. We know that with substitution treatments like methadone and buprenorphine, we have a very powerful medicine that can help people make positive changes and gain recovery, but we must not be careless in the way we do it, and we must help people to realize the other work they need to do alongside the medication part of the treatment. For individuals and their families, the gains they make in treatment are very much to do with the positives of the changes in their lives, whereas as a clinician, I focus more on the harmful aspects reducing, and we need to have a mix of these so that I would be measuring that there was less drug use and less injecting and less involvement with a bad subculture, whereas the family would be more likely to be looking at the improved relationships or getting back into education or into the work environment. Certainly within UK treatment services and in many other countries, the challenge for us should be to move up a gear to be more powerful in the wider parts of treatment alongside using medications. And the challenge is how to do that in a way that still allows the interventions to be personalized for the individual. There is a major danger of prematurely pushing people. For example, in the UK, there's a lot of encouragement for people to stop their maintenance treatment in the belief that it's no longer necessary. And it's likely that we are causing some of those patients who have been successful then to lose the stabilities they've achieved. So we need very much to have much more attention to the quality of treatment and an improvement agenda. Now, these factors matter greatly because the way in which we do our maintenance treatment affects whether people stay in treatment, it affects their recovery, and it affects their survival. We have a lot of improvements to make in the maintenance treatment field. So this is a field with, as we've heard, a very important evidence base. But let's look at some of the challenges we still have to make it better still. If we look at these retention data in patients in methadone treatment programs and buprenorphine treatment programs, here we can see, so this is the first 6 months of treatment from many trials around the world that have all been brought together in a meta-analysis. So we will see that at 6 months, nearly 40% of the patients have dropped out of treatment. So even if the ones staying in treatment are receiving benefit, one of the challenges for the next decade is to see how can we make our treatment better at delivering the benefit and at holding people in treatment during the months when they're going to derive the benefit. I'm sorry that this is a very dense slide, but it's pointing you to major reviews that are out there, which we can all publicly access. And Cochrane reviews have examined many of these different features of addictions treatment. And this is just one of the Cochrane reviews, which examines whether the dosing that we use, do we get better effects and better benefit from higher dosing? And this looks at the extremely important outcome of the mortality rate over the next few years. And patients treated with higher dose methadone substitution treatments have a lower mortality rate. Patients with a middle dose have a middle mortality rate, and patients maintained on the lowest dose have the highest mortality rate. So we have a lot of evidence out there from different countries. So we can look at the extent to which lessons are there for us to learn. I won't take many more minutes, but I'll just take you through a few other studies which show what I consider to be very interesting and important lessons. This was a study from Tom McClellan and colleagues in the US, where they wanted to look at the effect of dose in a different way. They wanted to use the idea of dose as being the dose of the social elements of the treatment. So not the drug element, but instead they wanted to have high dose of the social support that was given. So in their research study, one group of their patients with heroin addiction coming into methadone treatment had nothing except for the methadone prescription. Then a middle group had the methadone prescription with some counseling and the ordinary level of support. And then their third group had the methadone prescription with a very intensive social support and psychological support. And the results, what we were wanting to know was, were they just a little bit different? Because obviously you'd expect the patients with more support to do a bit better. Were they just a little bit different, or was there a major difference? Now, here's their results at 6 months, and let's just concentrate on the one that I've put a circle around just in the next minute. So this is the number who were still using heroin. So in the first orange column, we see that 60% were still using heroin for part of the time before the follow-up. So put the other way around, we have 40% who have completely quit their heroin use, but 60% still using. In the next group, with the ordinary level of support, we have better results. So there's only 40% still using. But the best results of all were in those with the intensive treatment, where only 20% of them were still using. So you have the social parts of that treatment approximately doubling the effect that was achieved with the medication on its own. So if this was another medicine, it would be as if you were saying that the two medicines combined have twice the power of the single medicine on their own. And yet we fail to recognize this. Can I check? I forgot to check the time before. Should I have just a few more minutes? Okay, I will skip through the next things. I wanted to, it was a slide already included from the previous speaker about needing to be very careful with the organization of providing methadone treatment. The drug is a very potent drug. It can be powerfully good, but if it's used clumsily, it can be dangerous. And this is a slide measuring the mortality rate of people at different stages of treatment and after they stop treatment. We obviously don't, this was studying individual patients, and so we obviously can't have a measure of what their mortality rate was from before we saw them, but it would from the mortality rate of their friends, it would have been at least 10 or above. During the first few weeks of their methadone treatment, there's a slightly increased mortality rate, which then drops to the very low levels of mortality risk whilst in methadone treatment. But the other point that the next 2 points here are of people when they quit their methadone treatment, that there's a rebound increased mortality risk. So when people finish their treatment, for a month or so, there's an increased risk of overdose death during that period. And as clinicians, we should be very attentive to this area. It means that if a patient is going to stop their methadone treatment, they've been in a treatment that has been holding them at a very low level of mortality, but for that first month or two, there's an increased mortality risk. And if we were treating other conditions in medicine, so if we were treating somebody's their epilepsy or their raised blood pressure, and we found that we could take them off their medication, perhaps they'd changed their lifestyle or had reduced weight and no longer needed those medications, we would realize that we needed to be more attentive than usual to the potential rebound risk of those complications. For the last few slides, we have a report which is available on the internet about trying to incorporate into our maintenance treatment more of the wider support to enable people to make fuller progress whilst in methadone treatment. There are some conclusions and warning notes, as well as positive notes, that I'd like to finish with. We were very struck by the fact that the heroin problem seems an extremely, we referred to it as a sticky problem. It was difficult to separate yourself from the problem once a heroin addiction problem had become established. That opiate substitution treatment is an extremely important part of the treatment and enabling somebody to break with their heroin use. And for the right patient at the right time, it can not only help with their broader recovery, but it also saves lives. But we also need to remember that it's a powerful treatment which, if applied carelessly, can do harm. We need to recognize the degrees of recovery, and for some people, their recovery will be less full than we hoped it would be, but it is still an important partial recovery. And our work should then be not to be judgmental, but to look at ways in which we can take that partial recovery and help them to achieve more. So it should be viewed as a platform. Your methadone treatment is a platform on which you stand, from which you hope to be able to achieve more. But we were particularly concerned that clinicians might be tempted to end that treatment too early. And so we wanted to issue a warning about the precautions that need to be made around ending treatment. And clinicians have increased responsibilities over that time to monitor how well the patient is doing beyond the completion of their treatment. I'll skip to the end and leave time for questions this week. Thanks.